Welcome to this explainer. Usually our skeletal system exists in this beautifully choreographed, perfectly balanced state. Osteoclasts break down old bone, and osteoblasts build up new bone. It's like a continuous, microscopic renovation project that keeps our skeleton strong and healthy. But what happens when that balance goes profoundly, bizarrely haywire? Well, let's dive into the fascinating world of metabolic and sclerosing bone disorders to find out.
Here's our agenda for today. We'll start with Paget's disease of bone, then move into sclerosing bone disorders, followed by fibrous dysplasia and MAS. After that, we'll tackle hypophosphatasia, ectopicosification, and FOP, and wrap the whole thing up with a master bone comparison.
Section 1. Paget's disease of bone.
Okay, so Paget's disease isn't just some static condition. It actually evolves through three very distinct phases. It all kicks off with phase 1, the osteolytic phase. Here, the osteoclasts become hyperactivated. We are literally talking up to 100 times their normal number. They just aggressively chew through the bone, creating what's known as an advancing lytic wedge. Then we enter phase 2, the mixed phase. The bone-building osteoblasts basically panic and try to overcompensate. They recruit massively and start laying down this rapid, disorganized woven bone instead of strong lamellar bone. It creates a sort of structural mosaic. Finally, there's phase 3, the sclerotic or burned-out phase. The resorption slows way down, leaving behind bone that is dense, poorly vascularized, and honestly structurally super weak.
Now, what's really interesting about this slide is how these physiological phases translate perfectly into the classic radiographic signs that clinicians use every single day to spot the disease. In the long bones, during that lytic phase we just talked about, that advancing wedge creates a blade of grass lesion. When you look at the skull, the mixed phase of lysis and sclerosis looks just like tufts of cotton wool. In the spine, cortical thickening around a sclerotic center gives you a picture frame vertebra, or if the whole thing is dense, an ivory vertebra. And down in the pelvis, which, by the way, is actually the most commonly involved site, you'll spot the brim sign, which is a thickened iliopectineal line.
This brings us to an absolutely critical clinical tip. When you're looking at a radiograph with dense, abnormal bone, differentiating Paget's from cancer, like a bone metastasis, is absolutely vital. The key differentiator? It's bone expansion. Paget's disease expands the entire bone or the affected area. Metastasis, on the other hand, does not expand the bone. It's a simple, high-yield rule, but it instantly points you in the right diagnostic direction, and obviously that fundamentally changes how a patient gets treated.
So, what is actually causing this crazy osteoclast hyperactivation in the first place? Well, the crucial culprit is a mutation in the SQTM1 gene. This mutation, which encodes the P62 protein, is for sure the absolute most common genetic abnormality found in both familial and sporadic cases of Paget's disease. Definitely lock that one in your memory.
When you're looking at lab work for Paget's, the serum calcium and phosphate are usually totally normal. The real test of choice here is serum total alkaline phosphatase, or ALP, which is going to be markedly elevated. To treat it, the first choice is a single IV infusion of zoledronic acid. It's a really potent bisphosphonate that normalizes bone turnover in over 90% of patients. There is, however, a massive warning to keep in mind here. Because you're rapidly shutting down bone resorption while bone formation continues, the bone will aggressively consume calcium. You have to ensure the patient has adequate calcium and vitamin D before giving bisphosphonates, or you risk plunging them into severe, life-threatening hypocalcemia.
All right, moving on to Section 2, sclerosing bone disorders.
The heavy hitter in this category is osteopetrosis. You might know it as marble bone disease. But here's the thing. Genetics heavily dictate survivability here. In infantile malignant osteopetrosis, which is autosomal recessive, the osteoclasts are fundamentally broken, often due to a TCIRG1 mutation. The bones become incredibly dense, but, paradoxically, really brittle. This extra bone narrows the cranial foraminus, causing nerve palsies, and it crowds out the marrow, causing severe pancytopenia. Without a bone marrow transplant, it's literally fatal before age 5. Now compare that infantile presentation to adult benign osteopetrosis. This form is autosomal dominant, and honestly, patients are often completely asymptomatic. It's usually discovered entirely incidentally on an X-ray that just happens to show alternating sclerotic bands in the vertebrae.
Another fascinating sclerosing disorder is pycnodysostosis, which is famously thought to have affected the painter Henri de Toulouse-Lautrec. It's caused by a mutation in the cathepsin-K gene. To easily remember the clinical features, we can use the OBBS mnemonic: frequent fractures, open patent fontanelles, blue sclera, a beaked nose with frontal bossing, and short stature. Now, unlike infantile osteopetrosis, these patients have totally normal serum chemistries and no anemia.
Before we leave sclerosing disorders, I really want to highlight osteopoikilosis. This presents as spotted bones. You get these round sclerotic foci scattered all over the epiphyses and metaphyses. It looks super alarming, but honestly, it's completely benign. So how do we prove it isn't cancer and reassure the patient? Well, osteopoikilosis lesions are stable over time and show zero radionuclide uptake on a bone scan. Metastases, on the other hand, are progressive and will rapidly accumulate that tracer.
Section 3. Fibrous dysplasia and MAS.
In these conditions, the whole issue starts with a post-zygotic activating mutation in the GNAS1 gene. This mutation causes mesenchymal cells to basically fail to differentiate into mature osteoblasts. Instead, you just get fibrous tissue and imperfect woven bone replacing normal bone. When this mesenchymal failure happens systemically, it presents as the McCune-Albright syndrome triad. First, you get polyostotic fibrous dysplasia, meaning multiple bones are affected. Second, characteristic café au lait skin spots. And third, endocrinopathy. Because the G protein signaling is basically stuck in the on position, endocrine glands hyperfunction. And by far the most common endocrine manifestation here is precocious puberty, particularly in girls.
And this brilliantly illustrates one of the most classic diagnostic visual cues in medicine. The café au lait spots in McCune-Albright syndrome have these rough, irregular borders, which we call coast of Maine spots. This is directly contrasted with the smooth-bordered coast of California spots seen in neurofibromatosis. It's just a small detail on the skin, but it gives you an immediate window into the genetic mutations happening deep within the body.
Section 4. Hypophosphatasia, the ALP paradox.
So, think about a patient presenting with classic signs of rickets or osteomalacia. Poorly mineralized, weak bones. Usually the body tries to compensate for that by pushing bone turnover markers sky high. So, I have a question for you. What is the only form of rickets or osteomalacia that presents with a low alkaline phosphatase? The answer? Hypophosphatasia. The crucial point here is that this disease is a major rule breaker. It's caused by a genetic deficiency in tissue nonspecific alkaline phosphatase, or TNSLP. Without this enzyme, an inhibitor called pyrophosphate accumulates, which completely blocks bone mineralization. It produces an osteomalacia pattern on an X-ray, sure, but the ALP is paradoxically low because the enzyme itself is what's missing. A massive, massive hallmark to watch out for in the childhood form of this disease is the premature loss of deciduous, or baby teeth, before the age of 5. Oh, and remember this? Bisphosphonates are absolutely contraindicated here. They'll literally just worsen the bone fragility.
Let's dive into Section 5, ectopic ossification and FOP. These conditions are fascinating, but honestly, they are truly devastating. We're talking about true bone forming in soft tissues where it absolutely positively does not belong. The most dramatic example is fibrodysplasia ossificans progressiva, or FOP. Driven by a mutation in the ACVR1 gene, this disease has a very specific diagnostic hallmark that's actually visible at birth: congenital deformities of the hands and feet, specifically a hallux valgus with a shortened first big toe. Over time, these patients experience episodic soft tissue swellings. The terrifying mechanism here is that even minor trauma, a bump, a bruise, a simple injection, triggers the connective tissue to permanently ossify into true, rigid heterotopic bone.
And there is a terrifying rule with this disease. Surgery is strictly contraindicated. In almost any other orthopedic mass, your instinct is to cut it out, right? Well, in FOP, if a surgeon attempts to remove the ectopic bone, the trauma of the surgery itself will precipitate massive new ossification right at the surgical site, rapidly worsening the patient's condition. Even local anesthetic injections for something as simple as dental work can cause jaw ossification, leading to a permanently frozen jaw.
Another notable ectopic condition is tumoral calcinosis. Now, this is entirely different from FOP. Here, a genetic mutation causes a deficiency or resistance to FGF23. Now, FGF23 normally tells the kidneys to excrete phosphate. Without it, the kidneys reabsorb way too much. This leads to very high serum phosphate, but very low urine phosphate. All that excess phosphate basically precipitates out, forming these periarticular chalk-like masses around the shoulders, hips, and ankles. But here's the good news. Because this is purely a mineral precipitation issue and not true progressive bone formation like FOP, surgical removal of these masses is actually an effective treatment.
Finally, Section 6, Master Bone Comparison. Let's synthesize all of this into an ultimate mental cheat sheet. Tracing the ALP levels, that's your best compass here.
If ALP is markedly elevated with normal calcium and you see expanded bone, it's Paget's. The key complication to watch for there is osteosarcoma, and you treat it with zoledronic acid. If the bones are dense and brittle, and the child has low calcium and anemia, you're looking at infantile osteopetrosis, which is fatal without a bone marrow transplant. If you've got fibrous bone lesions combined with precocious puberty and rough cafe au lait spots, you have McCune-Albright syndrome. And finally, if you see weak, unmineralized bones with a paradoxically low ALP and premature tooth loss, you've nailed the diagnosis of hypophosphatasia, which is treated with specific enzyme replacement, asfatase alpha.
I want to leave you with this final thought today. We tend to think of our skeleton as this static, unyielding scaffolding, right? But as we've seen today, it's actually a highly volatile, metabolically active tissue. If our bones can adapt to bear immense physical loads, yet be completely rewritten, dissolved, or over-solidified by just a single missing enzyme or a single hyperactive cell receptor, what other incredible paradoxes are hiding within human metabolism? Keep exploring, keep questioning, and I hope this explainer has illuminated the profound complexity of the human skeleton. Thanks for learning with me.